with Ray. So thanks for your patience as we switch the agenda around according to the needs of the group. I don't know anything about cookies.
Good afternoon, everyone. I'm waiting for my clicker. Thank you. Yeah. So thank you so much, Hattie, for this invitation, and thank you so much for humoring me for the next 20 minutes while we talk about something that's very important to Chloe and I, and that's disparities in cardiovascular care. Many different disparities exist. Today we're going to talk about disparities between men and women. These are my disclosures. There are so many disparities that we know of. They're race, gender, sexual orientation, so many. And there are so many reasons for disparities. And so that's beyond the scope of what we can talk about tonight. But we're going to sort of address a few highlights, things that we think are probably mostly at play here. One of the things that's mostly at play is that our evidence base and our research body is just not as great when it comes to knowing what works for women as it does for men. And this was highlighted by this publication from 2003, looking at diagnosis and treatment of coronary heart disease in women. Some interesting things came out. They found that research isn't always done in a sort of sex equitable way. So there are many research studies over the past 20 years in which women were excluded altogether. I started my career as a basic scientist, and for years we would order our rats, and they would always be male rats. And I used to ask, why do we do that? And they said, oh, those messy hormones, it made sense from a scientific point of view, but it doesn't necessarily make sense from a public health point of view to only look at men. And in many cases, when they did actually have a reasonable number of women in studies, they actually didn't always report sex-specific findings, so we were left to wonder. And the problem with that is because we assume that everybody reacts and does the same. So whatever we learned from research in men, we said, well, if it's good for men, it must work in women. So we just tried to do a direct translation. But we're now understanding that that's not always true and not always right. This is just an example. This is looking at non-invasive stress testing. We heard a lot about non-invasive assessment of coronary disease this morning. This is looking at stress testing. So the standard stress test that we do, the exercise treadmill test, either with imaging or without, almost all of that research was done in men. You can see the number of studies that were done with just a stress ECG, a stress echo, or imaging studies, many more in men than women. Men, the red bars, women, the yellow bars. So when you look at the results, what we end up with, many of our stress tests don't perform as well in women as they do in men. For instance, for stress ECG, for women, the sensitivity and specificity are only around 62% and 68%. So just does not perform as well. And that kind of makes sense because they really were not designed in that population. So again, many different reasons for the disparities, but what we're left with is that many preventive strategies, many active treatments, many interventions are not applied equally to men and women. Men tend to be overrepresented and women underrepresented in many things. This is looking at people, both men and women, who had the same diagnosis, the same risk profile. Turns out that women receive these preventive therapies less often than men, as shown there. The dark black line are women, the light gray line men. So for beta blockers, ACE inhibitors, statins, and antiplatelet agents, women are prescribed these agents less often. And the same goes for cardiac procedures. So PCI angioplasty, all procedures are actually applied less often in women than men. So I want to sort of frame this discussion around talking about two known beneficial therapies for reducing heart attack and stroke. One is a preventive medication, that's aspirin, and the other is a preventive strategy, that's blood pressure reduction. Both of these known to be beneficial, and I want to look at how there are differences in how they're applied, but also some real complexities in how we should apply them, so it's not always as easy as we think. So first we'll talk about aspirin. The benefits. Many studies have shown that for higher risk individuals, the benefits of aspirin in reducing ischemic cardiovascular events, heart attack and stroke primarily, are great. The benefits are greatest if the baseline risk of the patient is high. So if you look at this chart here, the high-risk patients, those who have a 10-year risk of having an event over the next 10 years, have the greatest bang for your buck, to say. No effect on total mortality, but you can avoid 6 to 20 coronary heart disease events. You might cause a few excess strokes, as that's shown there, and you might cause some more gastrointestinal bleeding events, but because heart attack events would be so reduced, it tends to be a very beneficial therapy. We actually learned about the benefits of aspirin in a population study that was done only in men, and I'll show you that in a minute. But when Rick Stafford and colleagues looked at how we use aspirin in real-life setting, he found that we don't always apply that therapy the same to men and women. So he used Medicare data from 1993 to 2003. I'm sorry, not Medicare data. It was the National Ambulatory Medical Care Survey data. And they wanted to evaluate aspirin use by cardiovascular risk level. They looked at about 50,000 individual visits, and they were able to get very specific visit information. So they knew about the patient demographics, they knew the diagnoses, they knew about how these physicians that were treating the patients, how they performed, how many tests they ordered, how many of their other patients were getting aspirin, and they knew about other concomitant medications. So they had a lot of data on what was going on. What they found was that if you were a high-risk patient, that's that light purple line above, you had the highest use of aspirin, and that makes sense. The lower-risk patients had lower usage, including patients with diabetes. That may or may not make sense. But what he also found was that there are different predictors of who was going to get aspirin. So if you had multiple risk factors, you were more than twice as likely to be prescribed aspirin. That makes sense. If you had diabetes, you were more than 3 times as likely to be prescribed aspirin as compared to a gender and diagnosis identical patient. If you were considered to be a high cardiovascular risk patient, you were much more likely to be given aspirin. Again, that makes sense, and you can see the age breakdown of who was likely to get aspirin. What doesn't make sense is that if you're a woman, regardless of your risk factor profile, regardless of your comorbidities, regardless of whether or not you needed aspirin, you're about 20% less likely to get aspirin. So they were able to see the stark gender differences there. Well, again, as I mentioned, there are complexities to all of this. It's not as easy as it sounds. As I mentioned, the first study that ever showed us that aspirin was beneficial for cardiovascular prevention was the physician health study. This was a study that was done in 22,000 men who were randomized to receive a full dose aspirin every other day or a placebo. These are all patients, or they are actually doctors, male physicians who had no cardiovascular disease. They got aspirin every other day or placebo. What they found was that there was a striking reduction in heart attacks, fatal heart attacks, non-fatal heart attacks, and total heart attacks in the men who got the aspirin. They were all 50 years of age and older, so they said, aspirin works. Aspirin significantly reduces the risk of MI in men. And based on that sort of recommendation translated to women too. We said, it works for men, it's got to work for women, right? Well, it took about 20 years later before they actually did this study in women. And the study was from the Nurses' Health Study, health professionals as well, but these were all women who were initially healthy. They were all 45 years of age or older, and they were randomized to low-dose aspirin every other day, and the dose they used was 100 milligrams every other day. So remember the men, they gave 325 milligrams every other day. For the women, they gave 100 milligrams every other day. I'm not sure how they came up with that dose, but what they did was they wanted to see who ended up getting a heart attack. When they went out to about 10 years, they found no difference at all. So you can see the yellow line and the red line are exactly superimposed. So despite the fact that we saw a very strong reduction in heart attacks in the men given this aspirin, we didn't see the same thing in women. So their conclusion was that this low-dose aspirin does not reduce the risk of heart attacks in women. But when you dig down deeper into that data, you see there are some populations that clearly benefited. So it reduced the risk of stroke and transient ischemic attacks in all of these women over the age of 45 if they got that low-dose aspirin. And in women who were over the age of 65, it reduced the risk of heart attack and stroke. So clearly there were some beneficial groups, but it wasn't as easy as it was with the men. With the men, every man 50 or older got the recommendation to get preventive aspirin. You can't make that same across-the-board recommendation for women. This also brought up some really interesting differences between the vascular beds of women and the vascular beds of men. What we found is that low-dose aspirin prevents heart attacks in men. It prevents strokes in women. So if you look at the data here, looking at the stroke reduction for women with low-dose aspirin, it's about 20%, but they actually, for men, had a slight increase in strokes. But middle-aged men have many more heart attacks and strokes, so they kind of said the overall benefit favors using aspirin. For heart attacks, women have a few more heart attacks given the aspirin, while men clearly have a reduction in heart attacks. Major coronary events and mortality were about the same, but there's clearly a difference between how men and how women respond. Is the difference in dosing? I don't know. Is it in body weight? I don't know. No one knows, but there's clearly a difference, which makes this a little more difficult. Next, I want to talk about a preventive strategy, that's blood pressure reduction. We know hypertension is very prevalent. In my sort of sick preventive cardiology joke circle, we say it's not whether or not you'll develop hypertension, it's whether or not you'll live long enough to develop hypertension, because we'll all get it sooner or later. And as you can see, in the younger ages, it's more prevalent in men, but as you get over the age of about 65, it's more prevalent in women. Because women live longer, there's a lot of older women with hypertension. We know benefits of treating. You can have a fabulous reduction in stroke by treating hypertension. You have a good reduction in myocardial infarction, and you have a phenomenal reduction in heart failure by treating hypertension. Clearly something we should do. If you actually look at the population attributable risk, it looks like you're bang for your buck in treating hypertension. It's great for everyone, but you actually get a slight bigger bang for your buck by treating women, either to a blood pressure of less than 120/80 versus treating men. Because, again, there are more elderly women with hypertension, and there's the reduction in stroke and heart failure and heart attack makes the number needed to treat to see a benefit in women pretty reasonable. But we don't always do that. Many studies have shown that goal attainment for blood pressure goals is lower in women than men. People don't know all the reasons why. Again, I think Chloe's going to tell us some of those, but what we do know is that actually having a frank discussion, a patient-provider discussion, makes a big difference. In this study, they looked at the impact of discussing coronary risk with patients receiving blood pressure medication. If you had just your usual treatment, pretty minimal reduction in blood pressure, but if you got specific risk counseling about the benefits of blood pressure reduction in reducing stroke and heart attack and heart failure, then you had much more blood pressure fall. You also, if you just have the usual treatment, Without risk counseling, you have the percent of people who got intensified blood pressure medication is lower than those who got the intensive counseling. So people do respond to the messages about risk, and if we have the time and the manpower to deliver them. But there are, again, complexities. This is some of it shown here. There's so much in the news now about what is the right blood pressure goal. Where should we go? Where should we treat? And who should get intensive? Who should you loosen up on treatment in? And that's been all in the news recently because of new guidelines that suggest in our older patients we should ease up on hypertension treatment and go to a goal of less than 150 rather than less than 140. I don't necessarily agree with that, but that is part of the discussion right now. There's also a big discussion about whether or not there's a J curve, meaning that we know that lowering blood pressure out of the dangerous range is beneficial, but is it dangerous to go too low? And that's shown in this chart here. What you see is that the hazard ratio for having a cardiac event is greater if you get your diastolic blood pressure below 60, then you go down to a beneficial range, and obviously if you get your diastolic too high, you get a lot more risk as well. So a J-curve probably exists for diastolic blood pressure, not systolic blood pressure, and it's probably most important for myocardial events, not stroke events, because all of the studies show it doesn't matter how low you get the blood pressure, strokes decrease. Then there's also a lot of new data on our elderly patients and how we should treat them. That's part of the impetus behind them lowering the blood pressure goals for elderly patients. This is an ambulatory blood pressure monitor tracing from a young patient and an elderly patient. And what you can see is that the young patient tends to have much lower blood pressure and much fewer excursions during the day. But because elderly patients have such stiff vessels, their blood pressure is higher to start with, and it just fluctuates all over the place during the day when they stand, when they sit, when they lie down. So they're much more prone to orthostatic hypotension, perhaps falls, and perhaps serious injuries. This was studied in a JAMA paper, a JAMA internal medicine paper from last year. They actually looked at Medicare beneficiaries, about 3,000 of them, and they all had hypertension. They did one-on-one interviews. They found out what medications they were taking, particularly antihypertensives. So they wanted to know how many and what doses they were taking. They then followed them prospectively for 3 years using Medicare claims data to track serious fall injuries. They found that about 9% over the course of that 3 years had a serious fall. And when they did multivariate analysis, they found that patients who used more antihypertensive medication and had more intensity of antihypertensive medication had more falls. So the hazard ratio for high antihypertensive therapy was 1.4, about 40% increased. For moderate intensity was 1.28, about 28% increase. And if you had one serious fall, you are more than twice as likely to have a second serious fall. So again, there are complexities here. We have to balance the benefits and the risk of treatment, and hypertension is one of the examples. So that's all I would like to say now, and then I will turn it over to my colleague, Dr. Bird. But gender disparities clearly exist. We know that underutilization of appropriate therapies leads to worse outcomes. So populations that don't get the benefit of our therapies or our interventions have higher morbidity and mortality, but we know that you always must balance risk and benefit. Thank you very much.